Okay, so you implement telemonitoring on patients with NIV in your daily work, and you've advocated on this subject for years. Question 1, what value does telemonitoring bring to your care organization and to your ventilated patients?
You know, telemonitoring is really an innovative way to manage these patients on the long term. Before telemonitoring, we were asking to the home care providers to send us every 6 months information regarding this patient. Now we are able to detect some unstable state, to anticipate exacerbation, for example, for COPD patient, and we have on a routine clinical practice information regarding adherence to an IV, but also leaks, residual events, and we can adapt the management and the care planning of these patients.
Excellent. So question 2, what barriers did you face when implementing telemonitoring in your organization? And do those barriers reflect the general limits you see for a broader clinical adoption?
You know, the limits are mainly regarding some ethical issues for the patients. Some patients do not accept easily to have a continuous information coming from their home to the hospital or to the home care providers. So we have to provide patients with an informed consent to explain why it is interesting for us to have a continuous information for daily management. This is one point. The second point is the organization of the different platforms between the hospital, the home care providers, and the patients to combine different information. For example, we have some electronic medical records with patients' comorbidities, medication, etc. And we have to synchronize this platform, the telemonitoring platform, and the electronic medical record to have the same the information at the same level inside the hospital. And we need some authorization. We have to convince the hospital that it's important to develop some connection between the different caregivers for a given patient.
Excellent. So question 3, have you experienced any reluctance from patients? And if so, what have been the main concerns?
No, actually we did publish last year a survey. It was not in non-invasive ventilation, but it was for telemonitoring in sleep apnea patient. And we found that nearly 90% of the patients were fine and accept to be telemonitored for following their OSA status. I think it's the same for non-invasive ventilation. So the reluctance is really limited.
That's great. So last question, question 4. For being able to properly manage the growing population of ventilated patients in the future, how does remote monitoring need to evolve and which functionalities need to be developed? We've been asked if you could consider touching on the topic of exception management based on alerts of monitoring breathing parameters.
I think we need to organize the telemonitoring platform by a shared management between physicians, probably some dedicated nurses trained to identify the different levels of alerts. You know, you have some different way to address this. Adherence is an issue, but if you have an increase in the number of residual events, in leaks, in the needs for non-invasive ventilation, this is a marker of an emergency, and we need to have to organize these alerts. And for this, probably a specific reimbursement should be associated with telemonitoring in non-invasive ventilation patients. There are also different strategies that should be implemented in different clinical situations. For example, for obesity hyperventilation syndrome, in this subgroup of patients, you have no so much exacerbation. So probably the organization should not be the same, but in patients with neuromuscular disorders, for example, with a high risk of exacerbation and hospitalization. So we have to have some common organization sharing dedicated nurses, expert clinicians, and some automation for the detection of problems, probably using artificial intelligence in the future.
Excellent. Last question.
Okay.
Question 5. Now and in the future, what impact can telemonitoring have in clinical practice on the patient therapy and treatment, and eventually on the relationship between the patient and the doctor?
Telemonitoring will be used more and more for titration of the settings, for non-invasive ventilation. You can imagine that we do not need hospitalization for non-invasive ventilation initiation or a reduction in the length of stay in the hospital, and then you can adapt progressively the settings using telemonitoring. So this is a completely new avenue. Reduction in cost is expected because the number of hospitalization for follow-up is going, and the number of visits, of outpatient visits, are going to be reduced. But again, to achieve these goals, we need an infrastructure regarding alerts, integrated care, and the different management by the nurses and by the physicians.